Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, it's Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Center. I help patients to effectively treat their hearing loss so that they can connect better with their friends and family and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. First to the hearing loss from radiation to his brain tumor, and then from complications from his brain tumor. I only care for ears. I'm the E of ENT. I've performed over 10,000 surgeries and taken care of many more with hearing loss. I'm the founder of Arizona Hearing Center and Listen Up Hearing Centers. I'm the author of a book, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more, go to www.listenuphearing.com, and you can learn more about the book and what we take care of. Today, I'm really excited about our guest. We have Dr. Nicholas Reed. He's an assistant professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, and he has an appointment in the Department of Otolaryngology, Head and Neck Surgery at the Johns Hopkins School of Medicine. Dr. Reed is also core faculty at the Cochlear Center for Hearing and Public Health, where he's the director of the audiology core. His areas of interest include access to hearing care, the impact of hearing loss on cognition, and hearing loss impact on the quality of care for patients. I'm really excited to have Nick on today. Nick, thank you so much for coming on to the podcast. It's great to have you here.
Oh, thank you for inviting me. I'm super excited to talk.
Yeah. So, one question I like to ask Nick is so now you're this guy doing this epidemiologic work and all of this stuff. So how did you get from being you before all this to this? Like, what was your pathway to this? How did you end up here?
Yeah. Depends how far back you want to go. I got into hearing care.
Not back to your parents getting how's that?
All the way back. Yeah. No, I mean, it is a family story. I think my great grandmother, I all joking, but sort of just the reality of the situation. I come from a long line of, let's say mistakes. Like I have a young family, and I grew up around my great grandmother, and she actually had a congenital hearing loss, and I grew up essentially like just taking apart her hearing aids, like all the time, and fixing them, doing random things. And I wanted to be an engineer because of that, and went to undergrad, did psychology and engineering, and somebody said to me one time, "You should be an audiologist," and that always stuck with me. I left. I had gotten really into the nonprofit side of the world, and I was in Indianapolis, and I was working for a nonprofit that was funneling state the Workforce Investment Act dollars through the Department of Labor into the Department of Education, and they were working with kids who were at risk of dropping out of high school in Indianapolis. And we had figured out this really cool program where we were, putting people into apprenticeships, and part of that was getting a medical eval. And I'm working with the bottom 10th percentile of students as far as grades and achievements in the high school system there.
The at-risk kids.
Highly at risk of dropping out. Yeah. And we found of 260 kids, we found 9 cases of hearing loss that only a few of them had actually been addressed, or those that, even there were some that they knew about it as a family and no one had done anything. And I was like, it just, somehow everything clicked all at once at that moment in time where I was like, I'm just going to drop everything and go back to school, and I want to do audiology. Fast forward a little bit, and I was at Georgetown University Hospital doing my 4th year, which is like audiology's externship.
Clinical skills up and focus.
Yeah. So it's like our big fellowship. And some people will call that a residency, but I actually don't like that. I don't like using that term for that. And you as a physician can probably appreciate that, because they're not the same thing. But I was doing mostly peds, which is where my interest was. And then I would get at Georgetown occasionally these folks who, either they're going off their parents' insurance, or they're relatively young and they have hearing loss, and they're struggling. They're struggling to get their next set of hearing aids, especially the ones who would transfer right off of their parents' hearing insurance. And they can't afford it. They don't know what to do about it. They don't know who to access. Some of them would go away to college and then send me emails, and they were like, what do I do when I have trouble here? there was something about the system that just wasn't sitting right with me. And I started looking into personal sound amplification products, which for your audience, those who don't know, are essentially these, off the shelf amplifiers. And I started evaluating them, and some of them were pretty good. A lot of them, though, just so your audience knows, were bad, really bad. But every now and then we'd find a good one, and we would use that as a solution. And uh, I then met Frank Lynn, my mentor, who's an otolaryngologist, like you, also just the E, an otologist. And he is also in epidemiology at Johns Hopkins, had been doing a lot of really big picture work on hearing loss and dementia and cognition. And um, we were chatting about something, and I said something about PSAPs, and he's like, "What do you think about that?" And I was like, "I think there's some really good ones out there." And he immediately basically was like, "You should come work in my lab as soon as you graduate."
Great. That's a great job interview.
I literally switched in like one day from being this peds clinical audiologist to, focusing on work of how do we think a little bit more about over-the-counter amplifiers for really older adult populations. He sort of opened my eyes up to we have a problem across the lifespan in terms of access.
Right.
But when you look at older adults, where we get into hearing loss numbers like 50% of adults over the age of 60, and we have really low uptake. And there's clearly some issues there, I think. And whether there's no one answer to everything, but it was just a real 360 of a career change all of a sudden there. So that's how I got all the way there.
So, talking about probably, as you know, some of the scenarios you're painting, kids transitioning to adulthood, and that there's some complex interfaces between various programs. We have the states have programs and stuff. So that's probably a bigger thing to digest. But let's talk a little bit about, people in the latter part of their life and getting access. So what are the things that seem to be limiting people's access now? And so as a context, this is being recorded in March after the Build Back Better, which was the people in the hearing industry and the hearing space thought maybe that hearing care would be expanded within Medicare for the elderly. It may or may not. I don't know. I don't have my ear to the ground. But as of now, it has not been. And as of now, I believe the working majority of the party of power doesn't even exist because one of their senators had a health issue. So he's out of town for at least 2 months. So we probably don't know, at least for now. But anyway, that's kind of the context. So there's been a big wave in the hearing space that, wow, these might be covered. What does that mean? And all of that. So, actually kind of what would be the rationale, or, obviously to some extent people would say, well, free is better than not. But, what I'd like to touch on is perhaps like the European experience where we see that they are covered and yet not as much penetration as we would hope because of coverage.
Yeah, I think that you are spot on with what you said at the end there, that we know that you can't just make hearing aids free and all of a sudden everybody's going to buy them, right? There's no way that's going to work. And we know that because there are places where they're free and covered and not everyone went and bought them. So there's clearly more to it. And
so the grim statistics are, correct me if I'm wrong, about 20% of people who should be treated for hearing loss with amplification are here. And in Europe, places where it's free, it's not much better.
Yeah, exactly. I think some of the best statistics are it's closer to like 40%. So sure, maybe double what we have here, but still nowhere near, 100% coverage. And the truth is, when you really start to compare out the systems and make, I think, more valid comparisons for like the UK, for example, I used to know the stat right off the top of my head, but it was like 22% here or something, or like 16.5% here using national data, and then like 26% there using national data. And it's like, yeah, there's clearly, it's clearly not just cost. I think when you break it down, it's cost is a factor, but so is access, the system itself. And I think that when we think about hearing care, we have a chronic condition, something that is an everyday part of your life. And the care model we've operated off of for 60 years now is an acute care model. where we really just you come in, you have this person who sort of treats you right there, and that's it, right? We fix your hearing aid and then you leave.
Yeah.
But it's much more of a lifestyle model, and
It's so interesting you say that because, I tell patients that hearing care, or that if you want to purchase hearing aids, then you're one and done or maybe three and done, right?
yeah,
Here are your hearing aids, come back and see us if you need us, or here are your hearing aids, here are two more visits, come back and see us if you need us, which if your primary care doctor said that about high blood pressure, you would look at them like they are crazy. Like, here's your blood pressure pill, come back and see us if you need us. I mean, it's a totally disparate concept, and it's got to be considered a health problem, not a social problem.
yeah, I'm with you 100%. I think that is a real problem in the model. And if you go back in time and think about like, well, how did we end up with that model? I think it's because a lot of our hearing care came from the actual hearing aid manufacturer side, which of course what they're doing is just they want to sell you a hearing aid and that's it, right? If you think about audiology's like birthplace, for a long time it was separate. What audiologists did was diagnose until you needed a hearing aid, and then someone else sold it to you. They were a company.
Yeah, the history, I don't know. I don't have I can't get it right, but Beltone and Miracle Ear, one was founded by vacuum salespeople and the other one was founded by car salespeople. So, and as well as I do, that the hearing aids started coming in the 50s and 60s, door-to-door sales, and audiology didn't get into hearing aids till the 80s, right? And so that has something to do with it.
Yeah, I think that has a lot to do with it. Actually, I really do believe that because the model of hearing care, like not just diagnostics, when audiology started delivering hearing aids, it was just based off of a manufacturer sales model, and we have pulled that over. And so, I think that's part of it. I think, of course, stigma is part of it still. I think people associate hearing aids with aging, for better or for worse, and they don't want to wear them. But I'll put a note in stigma for you and your audience that I like to tell people, and that's if you start to correct these other problems in the access and affordability of hearing aids, and start thinking about the technology themselves and improving that and improving uptake, well, stigma then may go down, right? If more people are wearing hearing aids, it may sort of decrease the stigma.
Well, I think ear level technology in terms of Bluetooth and things like that, earbuds have definitely done it. The other thing that I think, people don't appreciate it. I tell patients this all the time. People can already see your hearing loss, right? And so this concept that your untreated hearing loss is more invisible than your treated hearing loss. So it's kind of interesting. I had a conversation today with a patient. I said, well, do you know anybody who has hearing aids? She was in her late 60s. She said, well, I only know one person. I said, well, you only know one person that that they're wearing them, but you probably know many more people are wearing them and you can't see them and you don't know they have a hearing loss because it's treated.
Yeah. Yep. 100%. Yep. And you're right. People they know you have hearing loss, right? We know this. And the other sort of major end area for me that I sort of, when I'm thinking about why we've ended up where we are, it's sort of a broken model in that we have middlemen getting hearing care to people, and that leads to a situation where people really don't have very strong awareness of their hearing loss, because audiologists have operated under, again, a very sort of medical model where they're sitting in their office and they're sort of waiting for people to come to them. And the hearing aid companies, they market directly to audiologists, but because we have a low awareness of hearing loss, we could think about models like I'm sure we'll talk about today, like over-the-counter hearing aids a little bit, where companies actually focus on the population and help build awareness that way, right? And we have this a little bit in the medical system where the US is unique. I think it's just like the US and New Zealand, where pharmaceutical companies can advertise to people, and that builds awareness of conditions. Whereas we don't have that at all on the hearing side, right? Phonak and Sonova, and these are, for your audience, major hearing aid companies. They're not, up until recently, actually, you didn't see them putting out ads that were major public facing ads. And that,
it's a distributor model.
Yeah. Right.
It's not a direct to consumer model. It's a distributor.
Yep. Well, but the thing that gets me is that even under other distributor models, there are companies putting out, choose whatever, Celebrex or whatever, name a drug company, and they're putting out about their drug, and they're raising awareness. Now, yes, I have my own moral fortitude here where I think that we shouldn't be doing that perhaps, but you are raising awareness of conditions by putting on your television, people advertising their products. Whereas on the hearing side, we don't do that. We don't really raise awareness of hearing loss. In fact, the only thing the public ever sees is I have a 2-year-old, and we watch the movie Up sometimes, and they see that model of hearing is just something that hearing loss is something an older person has, and it's sort of a running joke, right? Of, they can't hear and they're turning up their hearing. That's sort of a problem. We've built a weird sort of awareness of solutions that instead we just further stigmatize it and put it in a corner.
Yeah, I wonder though, is that stigma due to actually the actual rehabilitation of the hearing? So, what I'm talking about is I think there's two problems. I think that there's untreated hearing loss, and then I think there is another epidemic of undertreated hearing.
Sure. Sure.
I think that actually is maybe the worst one, because the guy who has the hearing aid already treated the hearing loss. The question is the hearing loss treated appropriately? And so that becomes a huge part, because one of the stigma comes from experience, right? So somebody knows 3 people who got hearing aids. One returned them. The second doesn't wear them. They're in the nightstand drawer. And the third maybe wears them and doesn't hear any better. And so then the question becomes, why is that? And I would posit to you, a lot of that is poor care or poor programming.
Yeah, absolutely. Yeah. So there's some issues with sort of the model itself and what comes out of it. And it's funny. I actually, what you're talking about now is something I talk about in a different frame of work that I don't really think about it as much in this context, but we talk about precision audiology a little bit at our lab. And so we're thinking about big data and what can be done with in epidemiology. And we really don't have that, right? We sort of have this one size fits all hearing model is what's mostly applied out there as a field. And it doesn't
That's
work.
why I think people don't want to use it, because they don't get good care, right? So, I mean, it'd be like, okay, you have high blood pressure, everybody gets LASIK. Right?
Exactly.
And that becomes very, very troublesome. So,
yeah, I think you're absolutely right. I think that's, the other thing that, again, I don't put it under like the uptake aspect, but I do think that this is something to consider when we say that 20% of adults with hearing loss have, or only 20% of adults with hearing loss have hearing aids. One question I just sort of posit to the broad world is, well, do all of them need hearing aids? I'm not positive in my worldview that everybody with a mild hearing loss definitively needs hearing aids, and they might not be at that point. So
that's interesting, because the data, I mean, there are other people who are basically talking about a 20 dB hearing loss being impactful, right? Because, for the listeners, we consider 0 to 25 normal, but that's not necessarily you would love to believe that scale was based on clinical data that supports it to its fullest, but it's not. And so there's pretty good evidence emerging that, 20 dB is pretty significantly impaired, keeping in mind it's an exponential scale, right? And so every 3 dB is a doubling of intensity. So, I mean, that's the other thing. I'm not sure people actually comprehend that it's a logarithmic scale.
Yeah, it's funny. I had this conversation recently with somebody about the logarithmic scale, and they were like, "What are you talking about?" Because I was pointing out that I was like, well, 50 to 90 is 4 times as loud. 90 to 120 is 16 times as loud. I was like, guys, you're not making sense. No, I hear you that, I'm super familiar with some of the work, like Justin Collins' work, looking at subclinical hearing loss, actually, like, even any change is important. But I think this is what's important a little bit, is thinking about each person's individual factor. And, you go from like, let's say, for your audience sake, we won't get into the numbers, but you go from like a 0 to a 20 over a 10-year period. That's a huge change in someone's life.
But what if you started at -5 or -10?
Exactly. Yeah. Or you're like me, and for whatever reason, I don't know, I've never really looked into it, but I'm actually already up at like, when I was in my 20s, I already had like 15s and 20s across the board. And, if I go from 15 to 25, that's not as big of a change as some of these folks, like you said, like you're a -10 and you're going to like a 20, 25. So your own experience matters. And I think that, I think part of the problem with these big picture population level metrics is they're good for population level stuff, but they're not necessarily good for every single individual.
Well, so I guess so this is an interesting. I mean, we're kind of going down a different philosophical thing, but I think it's fascinating. So I actually am not sure that people's percept of their hearing loss matters one bit, right? And so
Hmm.
I'll just share with you. I had somebody in my life who died of complications of high blood pressure, and so I asked him, "Why didn't you treat your high blood pressure?" And his answer was, "Well, I felt good," right? And so there are very few I mean, some medical problems are correlated with a sense of not well-being, but the lack of symptomatology that says you're not well doesn't mean that you don't have a disease. And so people's ability to perceive their hearing loss, in my opinion, is I don't think there's a very good predictive ability to predict your hearing loss versus what it really is because of, speech reading and contextual brain correction. People communicate so you have a hearing loss, it all happens in my head. The conversation still happens in my head, but I'm actually not hearing it. My brain is
Yeah.
making up for it. Right?
Yeah. Well, I guess that's sort of my point, though, is that, of course, there are cut points and points where somebody, real hearing loss, right? And there's clearly going to be audibility problems. But, for me, I've been living around 15s and 20s forever. And I don't have a problem. And I've worn amplification plenty of times in my lab, and it's not something I need at this point in my life. Um, my own contextual cues and where my brain has been is where it is. But for somebody who, again, in that subclinical range, who goes from that -10 to 25, that's a huge difference for them, and their brain is working on that's a totally different input for that individual.
But how about even for you? You could argue that, you are allocating, to use a simpler concept, you're allocating more CPU power to your communication that perhaps if you did amplify yourself, that could free up capacity to do other things.
Well, I mean, maybe.
I don't know. I hope you're studying. Well, maybe you'll crack that protocol and have that study going by next week. I'm kidding.
Well, no, I guess the question is like, if you're sort of in a quote unquote sort of like low mild tier normal range, and that's where that you're just sitting where you've been for a long time, is your brain sort of tuned to that, right? And so does that mean you actually are using more power, or for that individual, is that sort of your norm?
Right. But I mean, we do also. So the question is I guess then the fascinating question is what's a little bit of high blood pressure?
Yeah, yeah, no, I mean, yeah, you're absolutely right. Yeah, what
And
is a
so
little? Yeah,
so it's right. So, obviously there are people who will smoke who will never get lung cancer, and there are people who will have uncontrolled hypertension and will never get a heart attack, right? And so I think what you're talking about is extrapolating concepts about populations to individuals. Because, on the flip side, and obviously it's all anecdotal, I can think of a patient who was running around 15 dB, and he is one of the happiest hearing aid users around. And, you have no idea how hard it is to get your colleagues to fit them because, this is a different conversation, how return rates are built into the culture of hearing care. And a lot of people don't even realize that. They'll say, well, you're not aidable. And what they've been taught by their mentor is, hey, you don't want to have high return rates, so don't even offer this person a hearing aid. You're not
no,
ready yet.
I think so. This is actually my point with precision audiology. The concept that you just posed, the one of the probably actually, you know what? Honestly, I barely do anything in the clinic anymore, but the person that stands out as probably the most successful hearing aid user I ever had. Same thing. I don't even know if technically they would have a hearing loss if you use the 4-point scale. Just 20s across the board, and they were not only were they a hearing aid user that was successful, they were a gain junkie, as I call them. They loved amplification.
Some people want to be overdriven by our metrics, right?
Yep. And so the point that I'm making is just sort of simply at a macro level. I think that it's hard to apply these big numbers across everybody and expect it to be. So I think there's plenty of people that flip to either side of that 20 or 25 or wherever you want to put cutoffs for hearing loss. So
Sure.
I'm not positive the denominators, right?
So this concept, when you use the term precision audiology, how do you define that?
A good question. I think
Is that a term you use in your lab, or is that a vernacular in your lab, or is that something that has some sort of operational definition outside of that? I mean, I'm fascinated. I've not heard that term.
no, it's for us, it's a term we've just been tossing around in our team where what I think a lot of us believe, and we don't have, believe me, we don't have an answer for this, and we're not really studying it deeply because it's hard, and we'd have to really we'd have to really, really do it. But I think to us, what it means is, what are the variables and components that we should be looking at to create custom approaches at an individual level? So taking the population level data and no longer saying like, hey, everybody who has, hearing loss X needs hearing aid Y, but instead, hey, hearing loss X plus being from X region and having, X language background, plus, also having this lifestyle and these other comorbidities equals any number of hearing aid outcomes and, auditory training programs with them or something like that. Like, we're thinking
are they still working, for instance?
Yeah.
Thing, right?
Yeah, exactly.
What type of rehab do you need if you're still working, you're in complex meeting environments as compared to, not that there's anything wrong with it, but, going and having maybe pancakes in the morning with a couple of buddies and going out with your spouse and another couple at night, or something, maybe it's not complex listening environments. No, I think that's so true. It's basically, and that's why, one of my mantras is, you don't get hearing aids, get your hearing loss treated. And so the concept is the devices themselves are just a big part of a huge process of actually getting you, it's kind of, there's things that are interesting, like a suit. Very few people would ever buy a suit off the rack. They just know that a suit should be somewhat bespoke and customized. And so the concept, and I do believe industry sells this, that it's the technology and not the care provider. So, I always ask people, what type of plywood did you have put in your home when you built it? And they look at me like, I don't know. I go, right, because you trusted the builder to pick the right plywood to put it in the house and put it together correctly. That's hearing care.
Yeah. Do you think our model of hearing care contributes to that sort of attitude that, hey, it's the technology, not the care provider?
100%, because basically, what do you tell people? Go get hearing aids.
Yeah.
No, don't get hearing aids. Go get your hearing loss treated. And so I talk about kind of the category of the sellers of hearing aids and the treaters of hearing loss and what the difference is. And I think the fundamental beginning is the sellers of hearing aids think it's about the commodity, and the treaters of hearing loss think it's a medical problem. So the first thing is I'm going to, regardless of what you do, we're going to see you in a year because we're going to monitor you, right? You now have a health problem called hearing loss, and we now will monitor you on a perpetual basis, because just like it's like, hey, you're hearing loss. Hey, you have high blood pressure. We gave you this pill. Come back and see us sometime if you need us. It's like, what is that?
Yeah. So, do you think, honestly, like I'm curious your thoughts on, so I think something that contributes to this highly is the bundling practices. I think that when
people bundle home construction.
Yeah, that's a good point. Yeah, that's true. And people still care about the building. A
lot of stuff. So, I think the issue becomes, there's a lot of, I think that the philosophical issue is bundling is an issue of bringing out the care model in one way, right? In other words, what you want to do is you want to separate the care from the device so you can kind of unbundle and spell that out to people. The other, and what I would tell you is, I believe the people who can successfully do that and continue to provide a continuum of care that gives people the necessary follow-up are small. In other words, you have to convince that person that they need the care every time. If you have a package, so, it's different because of health insurance, but the answer is people do expect you to say, hey, you have high blood pressure, come back in a year. Mm-hmm. And so I think in a lot of ways, bundling removes some of the barriers to access to the extent that people need to pre-purchase it. Now, that being said, the worst case are the people who come to see me who bought bundled services and don't even realize that it was bundled. And so that is a bungled bundle, but it's not means bundling done correctly is wrong.
I think my impression of you, though, is that you're doing hearing care right for whatever right is. Right. Whereas I think at a macro level, this is another thing where there's a lot of places out there where they, like we talked about, the medical model, they're just selling a hearing aid and come back and when you bundle it then and people, that masks all the services and they're
but that's just people teaching people to comparison shop or to what they're getting, right? I agree with you. An otolaryngologist's role is not to say, hey, go see the person in the back and get hearing aids. It's to converse in hearing loss, why it's impactful and all of that. And so, yeah, I think, those are different concepts. I mean, we chase people down who fail to follow up, right? As compared to looking at not providing a service as a way to save money, if that makes sense.
Yeah. Oh yeah. Oh yeah.
So, I mean, some of this is, you tell me 90% of hearing aids are within 2 dB of first fit. So first fit for the audience is what the algorithm from the company is, right? So that shows that 90% of hearing aids are not being adjusted by the professional. And so then when we start talking about real ear measurement, which is a way to validate it, why are we talking about NAL2 when, I think it's great. I think 30% of clinics or 40% have real ear measurement, but only 30% of those actually utilize it on a regular basis.
Yeah, I was about to say it's really low when you actually, it's not just owning the equipment, it's actually people that use it. Yeah.
Well, it's like birth control. It actually only works if you use it.
Yeah. Yeah.
Right? So I mean, in a lot of ways, I don't think it's necessarily changing the care model. I think it's for the lack of a better word, enforcing the care model. In other words, pushing people through awareness to know what really caring for hearing loss looks like. And that would be finding the journey, and then saying, this is the journey and this is what you should be getting. And I think free market will do that. It's this is like the opposite side of OTCs.
Yeah.
Right.
Yeah. But I think you bring up a good point that some market competition is not necessarily a bad thing, right? It's kind of a good thing.
Well, I think the role, I'll be interested to hear your take, but I think the role of OTCs is to clean out the middle.
Yeah.
So what I mean by that is if you will spend several thousands of dollars and you get bundled services and nobody gives you services and nobody actually adjusts your hearing aid and gives you a good custom prescription in your hearing device, and you can go and get the exact same hearing experience, which might be mediocre, with a OTC or PSAP, then why would you go to that middle tier place, right? And so people need to sharpen their skills. So that's what I think OTCs are going to do, is they're going to force people to either be good or be gone.
Yeah. I couldn't agree more with that statement. I actually think a lot of people see OTC as competition, and they're not. They're competition only if you're doing a really, really low board job. And instead, I see a lot of the world, and this is something I saw in my own practice. People who had hearing aids their whole lives, right? These are mostly, because I'm working mostly in pediatric, populations and young adults, and most of them are congenital hearing loss or progressive early onset hearing loss. And essentially, when we had to make these switches where they were like, okay, I just need something to get me through these classes I'm away at college, and we would be like, all right, use this amplifier or whatever just to get until you get back. They were like, all of a sudden, the professional started to matter to them more. Whereas the rest of their lives, they were like, yeah, we've had a good relationship. Dr. Reed, we've had a good relationship. I know you well, and I talk to you, but I was nothing more than a salesman and sort of to them, because I got them a hearing aid. We would sit, and I did real ear every time. I only worked at academic medical centers that, we were pretty good at what we did. And I think I shouldn't say salesman, because I don't think anyone thought of me that way, but I was still just some guy that did their hearing aids. And then when they had to change the technology and they saw this moment in time where all of a sudden that I'm like shepherding them through and like the captain of the ship, that was a real eye opener for them. And I think that it really actually helps the audiologist to show what you can do, what's in your pocket, and what you can actually do when you practice the top of your game. And that the hearing aids are, some people argue over this term. They don't like to call them commodities because they're medical devices, but they're just a piece of technology over here. The skill set of actually treating hearing loss is an actual skill set over here that the individual has. And the way you build those plans matter.
Right. So going back to the home thing, right? If you're going to build a brick wall, right? The bricks or the mason, what matters? We all know it's the mason, right? But the mason does not say, well, the bricks cost this much and I cost that much. They just say, this is how much it costs of the wall. And so that I think unbundling is a way that people are having a problem communicating their value absent a piece of paper that lists it out.
Yeah. Yeah. No, I think that's a good point. Yeah.
The value is the experience, right? And so that's why I think one of the things is until we elevate that, then the awareness is not, the negative stigma will go away when you got a bunch of people saying, oh my gosh, my hearing aids are so awesome. I would never go outside. I'd never go anywhere without them because I'm hearing so well with them. And so once you get that point, I mean, I can't tell you how many people I ask about real ear measurement, and they have, I mean, they're not getting it. It's that simple. Even if it's in the protocols of the organization. So some of the larger organizations that, move hearing aids have protocols that say they should do real ear measurement, but, and the science says you should only drive 55 miles an hour, right? And so, there's one thing of what the books say and another thing of what people actually do.
Yep. Nope. With you 100% there.
But so the question is it actually does tie into the whole cognition thing. If you have undertreated hearing loss, so let's say at some point we get evidence that shows that treating hearing loss helps with cognition or reverses it, right? And so, I know there are people who are very afraid to say that at this point, but, one comment I always say is, medicine started treating high blood pressure in the 1950s. And the definitive study that showed that treating high blood pressure reversed cardiovascular risk came out in 1974. So we tend to do things before we actually have all the evidence. So I'll leave it at that. But the question I have is how about undertreated hearing loss? That's my big concern, is people who believe that they're treating their hearing loss, but in the end, they're actually not having maximum rehabilitation. That to me is the biggest tragedy, because those people actually invested.
Yeah, 100%. I find this to be an extremely fascinating question. And I'll be honest with you, I actually look at it through a sort of other lens too, where the other angle of my work is in hearing loss and sort of healthcare system interactions. And sure. I do a lot with delirium. And I actually, we talk about adults with, who have hearing loss are at risk for older adults, they're higher risk for delirium because of social engagement in the environment that they're in. And what I actually really talk about though is, well, you guys, they go into the hospital, and what do hospitals do with hearing aids? They take them off and put them in drawers so they don't lose them, right? Hearing aids are, and you put that person at a pretty big risk. And I feel the same way about undertreated hearing loss, where you might have set that person up right in the beginning, but now you're sort of undertreating them. And over time, you're neglecting them and you're putting them in a worse situation where they've their brain has sort of tasted. Yeah, they've started to be treated. And then, potentially, almost like the best case scenario when it's undertreated is that it's statically undertreated, right? Or like linearly, like whereas the adapt to it. Yeah, the worst to me though is when maybe you started out kind of good, but you didn't give them a good care model, and their hearing loss is going one direction, and you're not doing anything over here, and then it's getting worse, and so their brain is going to have even more struggles to keep up. And so I know that sounds kind of weird, that it's like the undertreating to me is worse. Like, not only did they put investment in, but I actually think that's really, really difficult for the brain to deal with, like getting halfway there, right? Like, yeah, treating some is better than nothing. And I'm all about getting people into pathways.
Maybe not.
Yeah, exactly. Like we don't know for sure. And from a cognition standpoint, there is like this idea that, maybe it really does need to be the best practice. So I think this is a fascinating question. I don't have real research to back it up, but the delirium area though, I can tell you that is something that we've started to study in on. And we do have ideas that, once you remove somebody who's treated and then you take away or undertreat them with like maybe those pocket talker amplifiers, and you put them off kilter a little bit, you make their brain higher risk to experiencing a poor outcome.
Well, interesting. One of the studies would be, when you have people with an asymmetric discrimination, right? And so where, one of the questions that's not very clear is if somebody has a sensory a threshold issue and they need more volume, at what discrimination do you stop amplifying it because you're actually putting garbled sound into their brain?
Yeah.
Right. And, so this is when do you go from amplification to a cross, for instance, or a Baja or whatever. And so that's a fascinating thing, because many people just self-select, right? They realize they put that hearing aid in there and they actually hear worse, because it's just like, I'd say to people, it's like, you don't speak it, but it's like amplifying Mandarin Chinese into your one ear and you don't understand what that is, right? Because it's an understanding. So that's an interesting issue that you could actually increase your cognitive load by undertreatment.
Yeah, I know, again, it's not a term that actually really means anything. There's not good research behind it, but I think both of us are sort of talking about this broad concept of precision audiology is necessary, right? We really have to get to a point where we are fine tuning our hearing care program to each individual based off of all their different needs. And right now, like you said, like people sort of self-select into it and they sort of figure, we kind of do the best we can and figure it out. But this is science. I mean, there's an art to healthcare, but there's also a science we could be applying to thinking more about what to do in those situations. And I think you bring up in general, like the broader topic you're bringing up though, this idea of like off kilter and under treatment is a really, really fascinating topic that I don't think from a research standpoint, anybody's even scratched the surface of.
No, I don't think so. And those are the ones I really worry about. It's kind of you actually need 3 antihypertensives and you're only on 1.
Yeah.
So you're walking around with the belief that you're treated when you aren't, right?
Yeah.
Fascinating.
And also the undertreatment problem, like how many people does that contribute to who enter hearing care with all the right intentions and all the need, and then they're dejected afterwards? I mean, this is not,
I would argue that's the source of stigma.
Yeah, exactly. Like this is a big problem.
Hear dissatisfaction, right?
Yeah.
So the reason people don't want to treat their hearing loss is because they have nobody coming to them and saying, I treated my hearing loss like this is the best thing ever. The reason people get smartphones is because somebody says, I got a smartphone. This thing's awesome. You got to go get one, right? And so there is a huge part of that.
Yeah, I'm with you 100% there. I think that is a real, real big part of it.
Well, this has been great. We didn't actually hit the OTC side, but this has been a great conversation. We can do that for another episode sometime. But Nick, I really appreciate you coming on. There are a couple of questions I always like to ask people. One question I ask people is, if you were accepting a Lifetime Achievement Award, who would you thank? Like who, you always say, I want to thank. Who would those people be?
Oh, I'd thank my parents. That's so generic, but I would thank my parents.
I think that's wonderful. As a parent, I love that. That's awesome. Yeah. So the other question I was asking, what's your favorite sound?
This is actually this is a good question. And again, I'm going to give a corny answer, but it really is. And I can say this definitively now. I just had my first academic trip since COVID. I went away for a week. And I came back and my favorite sound is my kid's voice. I mean, I was listening to videos of him talking the whole time I was gone.
That's awesome.
That's all I want to hear. Like, yeah.
No, that's great. I get, the love of a parent is a profound thing. So yes, I agree with you 1,000%. So, we have Dr. Nicholas Reed here. He is in both the Bloomberg School at Johns Hopkins and the medical school there. He's an audiologist who studies hearing loss. Nick, if people wanted to get a hold of you, how would they get a hold of you? LinkedIn, or how would people reach out?
Sure. I'm active on Twitter, but I do have a LinkedIn. And honestly, we probably shouldn't be doing this, but my, Hopkins in general, our emails are like basically public. So if anybody has anything that's a burning question about our research, I'm happy to answer.
Well, this has been great. Thank you so much. As I said, I think, a little bit further down the line, and we would actually get to OTCs and talk about that. But this has been a great conversation. Thanks for coming on.
Thank you for having me.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.